and oncologic surgery. Let us start why this topic matters now. First, treatment for absolute uterine factor infertility, like Mullerian agenesis or Merck syndrome. Now more than 140 procedures worldwide with 70 live births, rapid surgical and immunological evolution. What is the history? First live birth was in Sweden. The recipient was Merck syndrome or Mullerian agenesis. Living donor was 61-year-old lady, Bara 2. The recipient received triple immunosuppression, azathioprine, calcineurin, and steroids. Preterm cesarean section is done at 31 weeks plus 5 days because of preeclampsia. The Apgar score of the baby was 9, 9, and 10, which was fine, the outcome, but it was only preterm. We will discuss the global registry data now. Now 91 procedures analyzed from 2000 to 2024. Living donor 67. Graft survival now 75%. Live birth rate 47 to 60%. What about the donor and recipient profile? Recipient mean age 29.5. 88% of them is Merck syndrome or Mullerian agenesis. About the donor, now living donor, mean age is 48.7, which is premenopausal, graft survival by 85%. What is the surgical concept? The donor will make radical hysterectomy like dissection with preservation of the long uterine artery pedicle and venous plexus preservation. This is important to control to the recipient, but it is risky for the donor because ureteric injury is more common in this dissection. We will discuss later this point. For the recipient, anastomosis will be in the external iliac vessels, vaginal anastomosis as well. Surgical anatomy is very important. Uterine artery is a branch from anterior division of the internal iliac artery, very important. Deep uterine vein from plexus draining to the internal iliac veins. Critical relationship, ureter passes under uterine artery or water under the bridge, as we explained before in another video you can refer to. External iliac vessels used for recipient anastomosis, very important, and we can see in the diagram. What about the operative technique? We will go through a step by step. First of all, donor selection and preoperative vascular imaging for CT angiography. Living donor is better for less ischemia time. Living donor radical hysterectomy will be done with extended vascular pedicles for the uterine artery, as we explained. Extensive uterolysis to preserve the blood supply. This step is very critical for the donor, have to be counseled because there is a high risk of ureteric injury and other complications of the urinary tract. But we have to discuss with the donor extensively in the consent. Retrieval with long uterine arteries and deep uterine veins. Cold perfusion, preservation. Recipient, laparotomy and preparation of external iliac vessels. The recipient will receive the anastomosis to the external iliac vessels in the two-side arterial anastomosis, venous anastomosis, the critical thrombosis risk step. We will discuss the vascular algorithm later. Vaginal anastomosis to the recipient vault, intraoperative Doppler confirmation of flu, very important step, and post-operative coagulation protocol as well, serial cervical biopsies for rejection monitoring. The vascular algorithm, post-operative decreased Doppler blood flow, detect immediate vascular imaging via Doppler CT angiography. If arterial thrombosis, urgent surgical re-exploration, very important. If venous thrombosis, thrombectomy plus or minus anticoagulation, advanced individualized. If graft non-viable, graft hysterectomy. Very important to avoid complications for the recipients like kidney injury, stable flow, continuous surveillance protocol. So this is the vascular complication algorithm, very important as well, because giving uterus to the recipient is the first step. The high risk zone reminder, the deep uterine venous plexus dissection, proximity to ureter and hypogastric nerve plexus. This landmark we explain in a video water under the bridge, and the hypogastric nerve plexus we explained in endometriosis surgery. As we discussed, you can refer to the video as well in the channel. Prolonged ischemia time increases thrombosis risk. Strict early Doppler monitoring is mandatory. As we explained, the Doppler monitoring is starting intraoperative and postoperative as well. Graft survival and the rejection, very critical step. 12 months survival, 75%. Early rejection, only 44%. Most failures, less than 6 months. Vascular thrombosis is the most common graft loss cause. What about the immunosuppression strategy? Induction by the triple and steroids, azathioprine, and steroids maintenance tacrolimus, azathioprine, steroid, complications expected hypertension, diabetes, and infection. What about the reproductive outcomes? 44 live births registry cohort. Live birth per embryo transfer is 30%, means 3.3 embryo transfer per birth. Median gestational age is 34 to 36 weeks. What about the pregnancy risk? We deal with this type of pregnancy as a high-risk pregnancy. It is a selected patient candidate for IVF. Embryo transfer is done, and after that, antenatal care is a high-risk pregnancy, expecting to have complications in pregnancy like preeclampsia in 15 to 22%, preterm birth 60 to 75%, 100% of them is cesarean delivery. The indication because vaginal anastomosis, vaginal stenosis, and no graft innervation to the uterus, so the patient cannot feel contraction, as well as vaginal stenosis, and to preserve the vascularity of the graft. Living versus deceased donor. Living donor, better vessel preparation, of course, but there is donor surgical risk. As we explained, we have urethrolysis dissection and the hypoplexus nerve injuries, very critical. We have to explain for the donor during counseling. About the deceased donor, no donor morbidity, very good benefit, but more ischemia time, which is very critical for the graft. What about the major complication? Vascular thrombosis, as we explained, it is the most common cause of rejection and acute rejection with its consequences of acute kidney injury. Immunosuppression morbidity, side effect of the medication, as we explained before, hypertension, diabetes, infection. About the psychological burden. So we are dealing with the donor in a multidisciplinary team, and we have to involve a psychiatrist in our MD team. What about the ethical framework? It is created by the American Society of Reproductive Medicine. It is vascularized composite allograft. Vascularized composite allograft. Life enhancing is not life saving, which is different from something like renal transplantation, which is life saving. It's life enhancing. Approved research only and mandatory graft removal to avoid long-term immunosuppression morbidity. So we have to explain for the recipient that after 1 or 2 pregnancies, live births, we have to remove the graft to avoid long-term morbidity of immunosuppression. What about 2025 systematic review update? We are dealing with the updates until 2025. Graft success is 74%. Live birth among viable grafts up to 83%. Robotic donor surgery increasing. Shorter interval to embryo transfer. Absolute uterine fertility factor for Merck most common. Merck syndrome or Mullerian agenesis syndrome is the most common cause for uterus transplantation. As we explained before, it's about 88%. Live birth per transplant is 50%. Most failure early, less than 6 months, because of vascular thrombosis, as we explained before. Multidisciplinary management is very essential as well. Counseling framework, how we will counsel the patient. We have to explain for both the donor and the recipient that it's experimental nature. Now it's a clinical treatment, surgical risk, as we explained, immunosuppression risk for the donor, of course, alternatives like surrogacy, adaptation, the MDT pathway, very important. So, uterine transplantation, technically feasible now. We are considering like high risk pregnancy, as we explained. There is complications of preeclampsia, preterm, gestational hypertension. Temporary transplant, we have to remove the graft after 1 or 2 live births to avoid long-term morbidity of the immunosuppressive drugs. Ethical complex, and it's a rapidly evolving field. If you find this video useful, like and subscribe. And if you want more questions, you can request in a comment my question bank. I will send you in private. See you in another video.